So now we have time for questions. So maybe while we are waiting for some questions online. Okay. I have a question for you, Julien. You were already talking about that, but the CIRCA trial is, I think, the example of the difficulties that we have in conducting large trials in cholangiocarcinoma. The trial was well designed, had, I think, simple inclusion criteria, but then most of the most important centers were involved, but then the accrual was too slow and the trial was stopped. So do you have any suggestion or idea on how we can do better for these trials? And also for all the speakers, because it's a general topic.
Now, this is a very important question, and we already discussed about the difficulty to conduct trial in rare disease and specifically in subgroups of the disease. We know this cholangio is heterogeneous. There are differences in molecular alteration, in primary location, and finding and focusing on subgroups within a personalized approach is difficult for inclusion in clinical trials. Well, I don't have answers. I was very disappointed, but one part of the question is also the implication of the industry in this trial, because they stopped quite early the trial despite 100 patients included. So if this trial has been academic, I'm pretty sure that we will have say, yes, it's going slowly, but well, we will be able to finish the trial. But then economic reason made the decision to stop the trial, and that's part of the difficulty.
Angela?
A little bit to the previous lectures about the awareness about the cancer of unknown primary and Tim, the project that you were presenting on the Think cholangiocarcinoma. And Juan, you very briefly mentioned that the cancer of unknown primary MDT at the CRIST is quite fine-tuned for thinking on cholangiomas. I think people may benefit from having a little bit of an explanation of how can we get this cancer of unknown primary MDTs really thinking on cholangio. And then Tim, about which was the strategy about how can we get all these people who don't really know much about cholangiocarcinoma thinking on cholangio. How can we make that a reality in our institutions?
Thank you, Angela. So I think our team in Manchester became quite engaged when we were doing a joint project together, specifically reviewing, so we systematically reviewed all of the patients within a time frame and re-looked at the images to see whether we could retrospectively identify patients who maybe had an intrahepatic cholangiocarcinoma. It was a work that was supported by a research fellow, and that obviously made things much easier. But as part of that project, they became very aware, particularly when the results came out, that if 1 in 9 patients actually has an intrahepatic cholangiocarcinoma, then this needs to go to a much higher list of priority. The unknown primary team are already used to putting patients into good prognostic groups, they're called. So, for example, patients with axillary lymph nodes who are more likely to have breast cancer, patients with inguinal lymph glands treated along kind of gynecological protocols, etc. So there are already some more favorable prognostic groups. The two things then happened. So one is that the COPISCO study, which is the big study in cancer of unknown primary that was running, published a paper looking at the methodology of the study, and they highlighted in their publication the identification of patients with cancer of unknown primary as a very discrete group, and they made recommendations that patients needed to be discussed at an HPV-MDT. And I think the second big step, which is what we were kind of gradually aiming for, was that it now appears in the ESMO guidelines to be thinking about cholangiocarcinoma. And so I think it's by influencing the guidelines, hopefully now people will become much more aware of it. And particularly when you're dealing with a liver-dominant lesion, that's now beginning to appear as one of these good prognostic groups where patients need to be referred.
Yeah,
mean,
I have done most when talking to pathologists, I guess. Although it's a little bit like this audience here, that the pathologists that I talk to most are those that self-identify as a liver pathologist, and therefore they will already think cholangiocarcinoma. So it's how do you reach the people that you can't reach? So in fact, on Tuesday, we're doing another webinar about reporting in cholangiocarcinoma in the area of personalised medicine, and your paper on the cup is part of that. At a personal level, the way I report, I probably try and leverage this perpetuation of a diagnosis, but the other way around. So I'll never report adenocarcinoma. I spend more time looking at the electronic patient record, though, than the slide. So if I can't find anyone recording, not irrespective of what's written on the form, anyone finding a tumour, a primary elsewhere, I will report it as cholangiocarcinoma, assuming the appropriate exclusion of extrahepatic, because at the very least, someone reading it will be thinking cholangiocarcinoma because I've written it down.
Radiologist, I think, could be key also, maybe all those snakes in the radiology reporting room or something.
Could I just pursue that a little? I mean, we know that upwards of 50% of the intrahepatics will have some kind of actionable alteration, some almost pathognomonic actionable alteration. Tim, I mean, you can save yourself a lot of time. Just don't look at it. Just do the profiling, and automatically 50% of them will diagnose themselves. I mean, slightly does you out of a job, but what's wrong with that?
Well, I basically agree, to be honest with you. I would still look at an H&E because I'm dressed like an H&E today, not deliberately, but I don't do any immuno. If there's no other primary to try and match it to, I won't do any immuno. It'll just be H&E, because then all the tissue is left for the things that matter to you and your patients, which is what can you do for them.
Okay, so that's a big message that could go straight to the CUP people. Don't forget about the immuno. It's pointless. Sorry, Chiara.
Yes, I mean, mine is a follow-up question looking on the other side, because I tend to see a tendency now where I don't participate to the MDT, the CUP MDT, but I tend to have referral from the MDT, which not always meet the criteria of a cholangio. So I agree when there is a dominant lesion, but if there are small multiple lesions, and patients have not undergone colonoscopies or gastroscopy or any other investigations, sometimes that might not be appropriate as well. So I think that the more we move on to this field, maybe we need to create harmonized guidelines of how we diagnose a cholangiocarcinoma and not just having a liver lesion. Like I do see sometimes now referral from patients with a liver lesion and not even having undergone a colonoscopy with a QFID positive test. So I think that the smaller the centers and less aware of all these issues, I think it's important to have kind of a guidelines for that as well.
Yeah, I kind of figure that no one's ever going to forget to think of colorectum as a primary site, but they might forget cholangio.
Just a question more widely about funding trials in cholangio and the difficulties you've just been discussing. My impression was that CRUC and other funders were becoming much more cognizant of the issues that we face as a international community trying to get these trials. We've talked a lot about the dream trials for various scenarios today. And I mean, what a heartbreaking scenario it would be if Shahid's trial at 1 year has not quite accrued all the momentum we've got to get to this point. I mean, maybe Helen or other one can talk to, what are we doing as a community to address this issue? And do we need a little bit more flexibility from funders in allowing longer recruitment times?
I mean, just a little bit of a reflection. So CRUK, in fact, have been very supportive of biliary tract cancer research. I have to give them complete due. They funded ABC01/2. They funded the BILCAP study. There was another study called PhotoStent, which was able to show that photodynamic therapy actually was detrimental to patients. So I think although we are a bit of a rare cancer within the larger CRUK portfolio. Thankfully, they've been able to support a lot of our work. So I'm hoping that they will continue to do so with the aspirin study. And I think it's really for us as a community to try and make sure that we generate that momentum to make sure that once again we've demonstrated feasibility. So, when we submitted ABC01 and 2, they didn't feel that a 400-patient study was feasible. It had never been done in the literature, but the community was able to deliver on that. So I'm sure we'll come up again.
Yeah, I mean, I was going to say, certainly liver cancer. I mean, when I first became consultant senior lecturer in 2007, I mean, it was impossible to get funding for liver cancer. Crux said it's not our top 5 cancer. We don't really give a crap. And MRC, didn't give much funding, and the Wellcome didn't do cancer funding. So things have really changed a lot. A lot of it was because of these, you guys and your ABC stuff. And then in terms of liver, the game changer, I think, was some big studies. So Mark Thurs's Stopper trial on alcoholic hepatitis. 1,000 patients, 50 centres around the UK, to show that the hepatology community could come together and deliver a huge investigator-led trial. I think that was on Alkep, prednisolone versus pentoxifylline, and then Helen Reeves in Newcastle got the big Hunter grant for HCC as part of an international collaboration. So I think it is changing. I think the challenge is, we are at the table now, right? I think the challenge is that there aren't that. Obviously, these cancers are devastating for those who get it, but overall, they're still a relatively small number of patients. And when you're looking at patients with cirrhosis or cholangio, one has to be a bit savvy as to how one recruits. And we can't do every trial. You can think of 100 trials, right? You can think of so many combinations and things that you'd like to do. And we as a community, not just in the UK, but I think internationally, have to really think, what are the priority trials? Because we have a limited number of goes at doing trials for these patients. So what's likely to give us biggest bang for our buck? And I think that's where the collaboration internationally as well comes in. Yeah.
So with respect to ABC10, which is our targeted study coming up again, CRUK really incredibly supportive, partly because we've delivered, over the years, and they know we can do that, and that we have an extremely collaborative investigator base out there, and that I'm sure that counts for 95%. Forget us, that's the most important thing. But the primary criticism, and it's come in again, and that protocol has been everywhere, it's come in again and again and again from everybody who's looked at it. How are you ever going to translate these very small numbers of patients with uncommon molecular alterations, small numbers of uncommon alterations, so small times small is very small, into standard of care, into practice? How are you ever going to be able to translate that? You're never going to be able to deliver a big randomized study in these small subgroups of uncommon cancers. And we couldn't answer that. We were unable to answer that question, and we bluffed our way through that on multiple occasions. However, very recently, there's now been a commissioning, that there's another way of getting your drug funded through the commissioning strategies. So the commissioners have recognized, primarily through the Determine study, and run through the Christie primarily. That has exactly the same thing. It has small numbers of uncommon alterations, and the Determined study must succeed, because it's like the baby. It's like the baby of the. It's a CRUK must succeed study, and so there's now a mechanism through commissioning by which the bar for evidence is lower, and these and you don't need big randomized studies to get treatment into standard of care practice. Juan, do you want to?
Yeah, I just wanted to also acknowledge the funding. Just as CRUK has funded ABC10 in the UK recognize the funding, which the equivalent of CRUK has been leveraged in France as well as Netherlands and Belgium. So it is something that's gathering momentum. So we're getting buy-in internationally from the various kind of CRUK equivalents.
Okay, brilliant. Thank you very much, gentlemen. Again, out of time. Great session. Okay.